awareness. This talk today will be recorded, and it'll be a good talk. The talk today is by Dr. Daniel Saban. He's the associate professor of ophthalmology and immunology at Duke University. He's the scientific director at the Foster Center for Ocular Immunology at Duke, and he's the director at the Ophthalmology Flow Cytometry Core Center here. He's also chairs the Immunology and Microbiology section program at ARVO, and he also chairs the Immunology Subcommittee for the Ryan Initiative for Macular Research. So a lot of leadership positions internally at Duke and externally across ARVO and the Ryan Initiative. So today he'll be talking about contribution of immune responses to the etiology of MGD, Meibomian gland dysfunction. So I'll hand it over to Dr. Saban to give us his talk now. Thanks.
Okay, great. And I've tried to make my talk about 45 minutes, and I'm not sure if along the way you want to ask questions, that's fine too. And then clearly there's going to be a Q&A at the end, right? And then I think another speech for that. Okay, let's get started. So next slide, okay. We can advance one more slide, please. So I'll apologize in advance because I don't know the level of I don't know the level of background for the folks joining on the call, whether they're ocular surface biologists or immunologists. So I'm just gonna give you as much background as possible and hopefully not offend anybody. Can I ask Peppy to turn off the mic in that room because I'm picking up?
Yes, you're getting background noise. I'll mute us.
And then if you have questions, then you can ask. Okay, so I know you're interested in dry eye. Dry eye is one form of disease. It is also sequelae of other diseases. So here you can see dry eye disease. Other ocular surface inflammatory diseases, for example, rosacea can affect the ocular surface. It's very common. Ocular allergy, there's your run-of-the-mill allergic conjunctivitis, which is an immediate hypersensitivity, but then there's more chronic forms, and I'll talk about that. Graft versus host disease, the eye is actually a target organ, an important target organ. Cicatricial pemphigoid, Sjogren's syndrome, Stevens-Johnson, all have or all can impact the ocular surface, and in ways that can target specifically either the lacrimal gland, not either, but simultaneously, in fact, the Meibomian gland, the epithelial layer, and can also have issues at the skin portion of the lid. Next slide, please. So one of the things we developed, and this was over 10 years ago now, was the allergic eye disease model. And this model is a model of allergic eye disease, obviously. At the time, there was only a mast cell mediated or self-limiting form of allergic conjunctivitis model that was available. It was very mild. And so we developed a system that would promote a stronger response and cause more sequelae to the ocular surface. And this turns out to be really the only mouse model of ocular surface disease that recapitulates a chronic form of ocular surface disease that can be seen with blepharitis, and I'll talk about that. So can you advance to the next slide, please? And so a lot of the things that manifest in our model, for example, and I will specifically talk about more focused on Meibomian gland dysfunction, but you can also see that there's fibrosis in the top right where we get remodeling of the tissue. On the bottom right, you get superficial punctate keratopathy, although we only see this in about 30% of the mice. And on the bottom left-hand side, you can see we get this pathologic mucoid discharge. And then in the middle, you can see just an en face view of the blepharitis. So you get this inflammation at the lid margin. Again, all of these aspects recapitulate what's seen in more chronic forms of ocular surface disease, which I mentioned before. Next, please. And we've had good productivity with this model and multiple collaborations, and this is an outdated list. We've worked with Charles Sirhan and Darlene Dart to look at goblet cell dysfunction. We've collaborated with John Dart at UCL to look at mucosal fibrosis, which they found to mimic a lot in ocular pemphigoid in humans. In the bottom left, we've actually looked specifically at fibrosis, but interestingly, dendritic cells initiating fibrosis, which was very novel. And then lastly, next slide, please. I'll be talking about Meibomian gland dysfunction. Here we called it sebaceous, eyelid sebaceous glands. These are eyelid sebaceous glands. They release meibum or lipid. It wasn't my choice to title it sebaceous glands. It was an editorial tinker to sort of capture a broader audience. But that's really what I'm going to be focusing on today. Next slide, please. So let me back up and just give you some background about these different glands with a more focused lens on Meibomian glands. So the tear film that sits on your ocular surface is quite sophisticated. You've got a mucin layer, which is ligated to the, these are mucins that are actually ligated to the cornea. On top of that, you have an aqueous layer, and this is produced largely by the lacrimal gland in humans. So when you hear the term aqueous deficient dry eye, that is a lack of this aqueous or lacrimal deficiency. And then you have the meibum, the Meibomian glands, which provide the lipid layer, the outermost layer. And what this layer does is several-fold. One is obviously to lubricate the ocular surface. Don't forget you're constantly blinking, and so if you don't have a wet, moist, slippery ocular surface, it would cause friction. Another is to form as a cap, so it prevents evaporation of the aqueous layer. So when you hear of evaporative dry eye, that's typically a dry eye form where you've lost your lipid layer. And so together, this allows for the homeostasis of the ocular surface. If you lose any of these, you could typically go into a chronic state of ocular surface disease. Next slide, please. So another look at the Meibomian glands. They line your eyelid, and their orifice is right at the lid margin. That's what I'm showing on the left. On the right, this is just a schematic of a cross-section of your lids, of our lids. And you can see the Meibomian glands, which sit in the tarsal plate, in the tarsus of the conjunctiva, and the pore of the Meibomian gland is right there at the lid margin. So when you blink, essentially, that constriction releases the meibum and provides the oil layer on the top of your tear film. Next slide, please. So here's a more zoomed in look. So in the middle, you can see the Meibomian gland. To the left is the conjunctiva. So this is the mucosal tissue. And then right above the conjunctiva, the green line going to the MCJ, which is the mucocutaneous junction. So this is where the conjunctiva now becomes skin and epidermis. And then you can actually see where the pore for the Meibomian gland is, the orifice is actually in the epidermal region. So this tarsal plate, which is where the Meibomian gland is situated, is partly in the conjunctiva and partly more towards the skin. So it sort of bridges both tissues. And so you can imagine that any kind of problem that impacts either the epidermis or the conjunctiva may have a downstream negative effect on the Meibomian gland. But specifically what you're looking at in this gland, you have the central duct, and then you have meibocytes, which are basically exocrine function. So they release the meibum, which is an oily substance, when they die. And these meibocytes sort of proliferate and continue to renew themselves. So one of the issues in aging is the loss of this generation or expansion or self-renewal of meibocytes, leading to the atrophy. But another problem, the most common problem, is actually obstruction of the orifice and central gland. And what happens is you can think about like a plumbing problem. You get a obstruction of the orifice and then essentially stasis, and then the central duct expands almost like a balloon. And that pressure also can lead to atrophy of the meibocytes as well. And I'll show you some of that. Next slide, please. So this is what I meant when I was talking about obstruction of the orifice. You can see on the right-hand side, it almost looks like pus, but what it is a thick and waxy substance. A healthy Meibomian gland expression is very olive oil-like, for lack of a better word. And when you have obstruction and stasis, that meibum turns into a waxy toothpaste-like substance, which needs to be expressed. This is the International Workshop definition of Meibomian gland dysfunction, established in 2011. This was a meeting from experts around the world. They define this, remember this is back in 2011, as a chronic diffuse abnormality of MGs, Meibomian glands, terminal duct obstruction, and or changes in glandular secretion. So you don't necessarily need to have duct obstruction. You can have impact on the glandular secretion, and so you're not producing happy or healthy meibum. This causes this can cause tear film changes, inflammation, and ocular surface disease. And the role, as stated in 2011, of inflammation in the etiology of MGD was controversial and uncertain at the time. So let me mention a couple things. One, I know the focus here is on dry eye disease, but it should be noted that one of the leading causes of dry eye disease is Meibomian gland dysfunction, right? And that's because those secretions are important for capping the surface of the ocular surface, of the tear film, and the aqueous right below it. So without that, you have evaporation and you have constant perturbation of the ocular surface without the smoothness of your lid wiper function, and perturbations from the environment lead to a chronic state. So it's important to understand that. The other thing is, a lot of patients, and I'm not a clinician, but knowing the literature and talking to clinicians and collaborating with them, ocular surface cornea external disease clinicians, they note that inflammation is often associated with MGD. And prior to this, it was thought, at least there was no consensus on whether inflammation was the consequence of Meibomian gland dysfunction or more upstream, meaning causative. And so you can imagine in a obstructive state where you have stasis, things are changing, you can then elicit an inflammatory attack of the glands or associated with inflammation, and that can exacerbate the picture, and that was what was thought. But there wasn't any conclusive direct evidence that inflammation or the immune cell compartment actually can contribute to the etiology of MGD. So that was where the big question was. Next slide, please. So if you look at, this is just adapted from that same paper. If you look at the layout or the structure of these diseases by this tree chart, Meibomian gland disease is a larger condition, and then within there are subsets. Meibomian gland dysfunction being the central, most prevalent form of Meibomian gland dysfunction, or disease rather. And then within MGD, really the largest number of people suffering from MGD, which is massive. I don't know what the numbers are off the top of my head, but these are low delivery obstructive. And you can see that there are two types. There's primary, and this is really not really well described, but on the other hand, there's secondary. And this means it's either a consequence or associated with other diseases. And if you look at the list, it's really interesting. Every single one of those diseases is associated with inflammation. So trachoma is an infection. Pemphigoid is an autoimmune, seborrheic dermatitis, acne rosacea, psoriasis, and then lastly, atopy, which is allergy. So patients with chronic allergic keratoconjunctivitis also routinely suffer from MGD. So when we saw this list, I was scratching my head and thinking to myself, how can you not make the connection between inflammation as potential causative with MGD as opposed to the other way around? I mean, MGD is not going to cause trachoma, or MGD is not going to cause seborrheic dermatitis or rosacea, but maybe the inflammation associated with those diseases is causing MGD. So to me, it was like, hello, why are we not picking up on this? Next slide, please. And next, again. So we knew about these risk factors associated with MGD, age. So you get, prevalence of MGD increases with age. There's a stronger prevalence with sex in females. The environment can be impactful. For example, in dry, desiccating environments, certain medications can also be associated, but none of these were really focused primarily on inflammation. Of course, you can have an environment where you stimulate inflammatory perturbations, such as in the city with diesel or allergens, for example. And obviously, aging is associated with changes in the immune activation, so-called inflammation. But the big question to us was, could the immunity, a dysregulated immune response, actually cause this obstruction? Not the other way around, not the obstruction causing an inflammatory response. And that was where we were looking to go. Next, please. So one of the reasons why we're interested in this is because we developed this AED model. Again, this is completely serendipitous. We developed the model to simply drive a chronic allergic state to better study the allergic eye disease, not to study MGD. So in the classical model, which I mentioned before, that was already around, which I refer to here as mild because it's mast cell mediated and self-limiting. Essentially, without going into too much details, is that you immunize mice with a model antigen. Here it's ovalbumin. You mix it with an adjuvant, pertussis alum, which drives a Th2 response. And you get an allergic response. You get these markers of allergy, which is hyperemia, increased tearing, lid swelling, etc. But those last for about 20 minutes and then they subside. What we did was to add pertussis toxin to this bolus, and the reason why is that there was an article, which unfortunately I didn't cite here, from Japan, showing that pertussis toxin can help drive eosinophilia. And that was interesting to us because we knew that eosinophils actually drive more chronic state inflammation. So we added, we titrated these doses, and lo and behold, we got a more severe disease. As you can see here, we were able, in some mice, 30% show this punctate keratopathy, which is a pathognomonic of dry eye. And then you can see this is what we often, or I would say over 95% of the mice get, which is this plugging, which I showed you looks like what you see in human. You call it plugging, it's called obstruction, it's also called capping. But you don't see this capping or plugging, I'm going to refer to as plugging from here in the mild model. Next slide, please. So I thought we saw these plugs, my postdoc and I, and we said, wow, this looks like MGD. We had no clue what MGD was. But then we went into the literature and we're like, well, this doesn't make sense that inflammation can't cause MGD because we have here an inflammatory model and we see that it's associated with MGD. And so we decided to sort of look at this a little bit more closely. Now, what I'm showing here are clinical scores. This is a combination score. We've published on this. We didn't invent the scoring scheme, but essentially it's hyperemia, lid swelling, chemosis, and tear discharge, which is done on a mass fashion from 0 to 3, and then summed and added. So you challenge the mouse with topical ovalbumin, which is the model antigen you systemically immunize them to. And then they get an inflammatory response that you can measure using a slit lamp. And what you can see in both the mild and the AED models, which we're calling it the allergic eye disease model, which is the chronic, you can see both within 20 minutes after the challenge, each challenge once a day, you can see the response in both of them kind of went up. And there's once the AED is statistically higher, but it's not really that impressively different than the mild model. But when you look at 6 hours, and at the time nobody was looking at this 6 hour time point, and we decided to because we're more interested in the chronic response, you can see that this 20-minute inflammatory response is sustained out to 6 hours, and we see the same thing at 24 hours. And this is a hallmark of a chronic non-self-limiting response. So there's clearly more inflammation, at least from the clinical standpoint, and this was sustained. So we thought we had something really interesting. Next slide, please. And what we did was just to take the conjunctiva, enzymatically digest it into single cells, and look at flow cytometry by CD45 cells, which CD45, which is a marker of immune cells, a broad spectrum marker. And you can see, indeed, consistent with the inflammatory clinical scores, the mild versus the AED. In the AED, you saw a lot more CD45 cells in the conjunctiva that infiltrate the conjunctiva. And indeed, you can see a lot more eosinophils. So this is a hallmark of our AED model, tons of eosinophils. And you can see it's much higher in the mild. So this was, next slide, please. This was matched very nicely with our clinical data. The other thing is, when we started showing our plugging data to some of our colleagues that were experts, we weren't experts in MGD, they said, okay, it's interesting. It looks like you have some kind of tissue at the lid margin of the eyes of these mice, but what's going on in the gland? So we teamed up here with Rachel Redfern and Carolina Coonan. I believe Coonan is no longer at Houston. But they were doing some imaging, near-infrared imaging, meibography in mice. So we asked them to take a look at our lids from these AED mice. So what you're looking here is, this is a binarized image of the Meibomian gland in mice, the top lid versus the bottom lid. Outlined in red is the whole gland. And in red here is, you can see basically the central duct, just so you're oriented. And what we did was to just quantify the area based on this image. And what we found is that if you look at all of the glands, or you look at the superior or inferior, you can see that there's clearly a reduction in the area, indicating, suggestive potentially of some level of atrophy that occurs along with the plugging. Next slide, please. And what we also did some histopathology. This is very challenging because the glands, as you saw in the previous picture, they're not situated perfectly perpendicular. They move around. Plus, the orifice and the central duct is not very large, and so getting right in the middle of these things is really challenging. What you can see here in the naive healthy mouse, here's the orifice in one section. These are serial sections, and you can begin to see the gland. I can't use my pointer, but you can see hopefully you can see the gland right adjacent to the conjunctiva side on the opposite side of the skin. And in the, so thank you. And you can see the terminal duct on the naive side where I've showed the terminal duct. And then you can see the central duct, which I'm showing in the naive. And then you can see the acini, which you can see here of the MGs in the naive. And they look relatively plump, like a plump grape. Now, if you juxtapose that to the AED, you can see some thickening of the epithelial tissue that we're not able to find the orifice. And if you look at the terminal duct and then in the central duct, so look in comparing the central duct of the AED versus the central duct in naive, you can see that it's sort of bloated. And that is, think of it like, again, like a plumbing problem. So you have obstruction at the top, and so you have stasis, but still production of the gland. Of the Meibomian, so that causes an inflation of the central duct, and that causes more pressure and causes more pathology to the meibocytes. So if you look at the acini, which is where the meibocytes are, if you compare them, as opposed to looking like grapes, they look a little bit more like raisins. So they're unhappy. And then the tissue, the tarsal tissue you can see between the acini, you can see is thickened and it's infiltrated with immune cells, which might be difficult to see. So there's clearly pathology, not only at the orifice, but also features that are pathognomonic of meibomian gland dysfunction and atrophy. Next slide, please. So, okay, so we have a model, we see MGD, and we're trying to claim that this is an immune-mediated phenomenon. So let's dissect the immune response to see which may be associated, if we are right, if our hypothesis is right. So you can start at the adaptive immune compartment. Those are the T helper cells. The CD4 cells is one, which we were familiar with. Allergy is typically a T helper 2 response, which you see at the bottom right. So it secretes IL-4, IL-5, IL-13, for example. Th1 secretes, the CD4 helpers secrete interferon gamma, for example. On the top left is a T helper 17 flavor, which releases or liberates IL-17, also IL-22, and to some extent 21. And then on the bottom, which I'm not going to talk about, are the Tregs. So these are antigen-specific T cell suppressors that help mitigate or suppress a response. So if you go to the next slide, please. So we wanted to see which one of these populations might be preferentially expanded in the lymph node in the context of the AED mouse to start giving us some clues. So clearly on the left-hand side, we were seeing IL-13, we saw IL-5. IL-4 is difficult. And bottom line is we knew that there was going to be a really nice Th2 response because this is an allergy model, and we designed it that way, and we saw plenty of eosinophils. We also saw interferon gamma T helper cells. You can see that in the AED model as well, and that was interesting. But the most interesting to us was this Th17, IL-17 secreting cell, which you can see on the right-hand side. And the reason why we're interested in Th17 at the time was because nobody had described it in the context of ocular allergy. This is way early in the 2010s, 2009, when we started developing this. Nobody was really looking at IL-17, and they were trying to, but I didn't see anything credible in the literature regarding ocular allergy. So we really honed in on this. Again, completely serendipitous of whether this was related to MGD. Okay, so next slide. So after we got to thinking, we said, okay, this is IL-17. This is one thing we don't see in the mild model. Maybe, is it possible that it's doing something potentially causing MGD? And so we set up this relatively simple experiment, which took some time to figure out. Essentially what we did was we made the mild model. Remember, those don't get MGD. And we adoptively transferred, so we IV transferred Th17 cells that we polarized in a dish to respond to ovalbumin. And then we challenged the mice, and we looked to see if now these mice can now suffer from MGD, or now show signs of MGD. Next, please. And so what I'm showing you on the top is the mild model without, on the left, the top fax plot on the left is just without any transfer, just the mild model. In the middle plot is a transfer of T helper 2 cells that we generated in a dish. You can see no increase in Th17 cells. And then on the right-hand plot, you can see the mild model where we transferred Th17 polarized cells. So we were very happy with our ability to transfer these cells. You can see the numbers on the bottom left. Next slide, please. And so what we did, and I'm not showing you the plugging data, but I'll show it to you in a bit, or the clinical images. What we found is that these mice now have plugs, which I showed you previously. All of a sudden, we can now find these plugs, and they're statistically increased. And when we transferred the Th2 cells, we didn't get a really large increase in the number of plugging, suggesting that this is really more of a Th17 response. Next slide, please.
So, Danny, this is Epi. I guess a quick question about the IL-17 association. I mean, do you think that's why psoriasis patients are prone to having secondary MGD? I mean, that's an IL-17 driven disease.
I agree. I think it can be. And in fact, I just don't have time, but I've talked to clinicians to collaborate, in a dermatology or even in ophthalmology to look at these patients, especially patients on anti-IL-23 or anti-IL-17. And I've heard anecdotally from docs who are treating some of these patients that, their ocular surface looks better. So yeah, I would totally agree with you. It just hasn't been tried.
Thank you.
Okay. So I guess at this point we thought, IL-17, this is pretty convincing. Let's try IL-17 genetic knockouts. And this was a collaboration with Amanda McLeod, who's no longer at Duke. I think she's at GSK, but I don't remember. So we induced AED in these mice. And these are IL-17 knockout. And you can see in the panel in A, you see in just your wild type in the lymph node, plenty of IL-17 cells. In the IL-17A knockout, we couldn't find a very good amount of IL-17 positive CD4 T cells, and that's quantified. Next, please. Next slide, yeah. And what you can see is in these mice, in the wild type, as we expected, you can see this nice plugging at the Meibomian glands, but in the IL-17 knockout, they seem to be protected from plugging. So further giving us evidence that this is an IL-17 mediated response. Next, please. So another step we did was to use IL-23 blockade. IL-23 is a cytokine produced by antigen-presenting cells. They stabilize the pathogenic Th17 cell. And in fact, it's now better understood that these make also interferon gamma. So essentially what IL-23 does is sustain the Th17 pathogenic response. And so what we did in this experiment is to impair the expansion and survival of the Th17 response by blocking IL-23. So we immunized these mice, and during the rest period, the 2-week rest period, we blocked their IL-23 to reduce the number of Th17 cells proliferating, expanding to the IP immunization. And then we challenged the mice from day 1 to day 7, as we do typically. In B, you can see that we were able to eliminate about 50%, about 50% of the T helper 17 cells in the lymph node. So we're pretty happy with our ability to cut that down. And next slide, please. And indeed, we were able to show that with the anti-IL-23, we can reduce plugging. So we're protecting mice from this response.
And then, did you give the anti-IL-23 systemically or topically?
Systemically.
Okay.
So remember, with if you see in A, the way the model is, we immunize them systemically, and then we rest them for 2 weeks, and then we challenge them topically. So the Th17 priming response happens right after day -14. So what we're doing is we're impairing the expansion of Th17, not stopping them from coming, not directly stopping them from coming to the ocular surface, if that makes sense. Okay, so yeah.
I have a question.
Yeah, please.
In your model, do you see other systemic phenotype? I mean, aside from the plugs, in other organ systems?
No, because if you look at A, our model in A, the challenge is just topically administered to the ocular surface with eye drops.
Ah, okay.
Yeah.
Thank you.
I don't think I did a good job of explaining the model in the beginning, so I apologize. Okay, next slide, please. So we felt with these data pretty confident in our model that the Th17 pathway is mediating this MGD response. As an immunologist, we know that the T helper cells are not necessarily effector cells, although they're called effector cells to some degree by some, but typically they recruit in, they need help, or they give help to. So for example, in an allergic reaction, the T helper 2 cells call in or activate and prime eosinophils. They also call B cells and proliferate germinal centers to start releasing antibodies, etc. The antibodies can obviously ligate to mast cells to release an allergic response, histamines. Th1, for example, recruits monocytes and activates macrophages. And then finally, relevant here is Th17. So there's a very tight correlation with Th17 in the recruitment of neutrophils. And that's not done directly, it's done indirectly. And so we're interested in seeking whether the Th17 response was associated with a neutrophil recruitment or activation of some sort. And so we looked at our data set. We analyzed the neutrophil numbers. So that's Ly6G, as you can see in A. So Siglec-F marks eosinophils. Ly6G positive, Siglec-F negative marks neutrophils. And you can see that in our anti-IL-23, if you remember, that reduced the number of Th17 cells, was associated with a reduction of neutrophils in the conjunctiva of these mice. So when we impaired the Th17 system, we saw a reduction of neutrophils. And the other thing we did was we went back to our adoptive transfer study experiment where we used mild mice and we adoptively transferred, this is in B here, we adoptively transferred Th2 cells versus Th17. And what you can see is that with the adoptive transfer of Th17, we saw an increase of neutrophils, together suggesting to us that there was an association between the activation of Th17 and the recruitment of neutrophils into the conjunctiva. Next slide, please. So we wondered whether the neutrophils were the bad guys and the Th17 cells were sort of part of the process, but more so in the recruitment or partially in the recruitment of neutrophils. And so what we did here was to use the same model again. You immunize systemically, you rest them for 2 weeks. And then what we did was to make these mice neutropenic, and we did that by anti-Ly6G, but we provided the anti-Ly6G during the challenge phase, not during the rest phase. So what we're doing is trying to deplete or making it neutropenic so that less cells, less neutrophils can infiltrate into the conjunctival tissue. And that's indeed what we saw. You can see that in panel B. We were able to induce neutropenia in these mice. And what you can see now in panel C, when you compare the AED mice that were treated with isotype control, again, this is systemic versus anti-Ly6G systemic, you can see that we were able to protect the mice from MG plug-in, as all the way on the right shown in the graph, in the dot plot graph, bar graph. So next slide, please. So the working model we have currently, and we have some data for dendritic cells too, which I'm not showing, but the idea is that in the normal conjunctiva on the left, you have dendritic cells, and those dendritic cells might get primed, might get activated to initiate a Th17 response. It's also possible that the Th17 response is active systemically. For example, the case may be in psoriasis. And so now you already have Th17 cells swimming in your blood or ready to engage from the lymph node. And you just need a DC. to get to the lymph node and reactivate those cells. And you have some sort of inflammatory event where these Th17 cells are now getting recruited into the conjunctival tissue. And then they call in, because they're secreting IL-17, or maybe not directly through IL-17, indirectly through the endothelial cell or an epithelial cell, are now resulting in calling in these neutrophils. And neutrophils then basically infiltrate in the tarsus. And we have some data now in showing neutrophils in the tarsal plate. And we now have some data about single-cell data about different neutrophil heterogeneous populations that might be implicated in this causation, lead to essentially the plugging of the gland. So that's the big picture. Next slide, please. Okay, so in the last few minutes, I'm just going to show you some stuff where we tried to see whether this might be relevant in the human context. So around that time, we were at Arvo, and I remember seeing a poster from a group in Alabama, I think it was Nichols, and the postdoc had come from Calgary, I believe, and they were doing flow cytometry of tear washes from patients. And I thought this was outstanding. We do a lot of flow cytometry, obviously, and I thought this would be great because you can get tear washes relatively easy from patients. You don't have to draw blood. You don't have to do a conj impression. It's really simple, and it's actually quite nice because when you put the PBS or saline on the topically to collect, it's actually refreshing because it's cold. So a lot of these patients actually like it. It's really easy to collect cells, and in an inflamed hot eye, you can get plenty of cells. You can get hundreds to thousands. And so we figured we would try this. So we collaborated and did a pilot experiment with Andrea Leonardi in Padua, because he had a lot of AKC, allergic keratoconjunctivitis patients. He also had other blepharoconjunctivitis patients with MGD, and I asked him to do basically a smear of the tear cells to see if he found any, with a simple Giemsa stain, see if he saw any neutrophils. And indeed he did. We have that in the supplement here in this paper, and it seemed to be associated with MGD, although this was not statistically rigorous, this pilot experiment. So we decided to do this in a more scientific fashion, and we teamed up with Priya Gupta, who's no longer at Duke, to essentially collect tears and run flow cytometry. And this is our flow cytometry scheme, showing that this is a Sjogren syndrome patient, showing that we can indeed capture neutrophils in the tears. And so if you think about the tears sort of like a bronchial lavage, where you're capturing fluids from the organ, and those fluids give you some information about what is happening immunologically at the tissue level. And by the way, neutrophils are really good at getting into the tears because they have tons of, they can drill through the tissue really easily with their MMP profiles. So, and they can slough up from the epithelial layer. So you can really capture a lot of neutrophils relatively well in the tears. Okay, next slide, please. And so what we did was we had patients, each dot represents a different patient. We had a control patient, basically a healthy control, which was age matched. I think we did pretty well with sex matching, but I can't remember off the top of my head. So these were age matched controls. What you're seeing is when I say MGD only, what that means is these patients had MGD, but no underlying systemic immunologic disease such as Sjogren syndrome or atopic or any atopy or GVHD, nothing like that. Whereas MGD plus IMD, that means underlying systemic immune disease, the patients, and I don't remember the breakdown of the patients, but they either had Sjogren's or atopy or GVHD. Again, I don't remember off the top of my head. And actually, these data separated out. This was sort of a data-driven separation of these two populations, as opposed to us sort of bucketing them at the outset. And so what you can see is there's clearly more immune cells in MGD patients and MGD patients plus systemic immune disease. And you can see that's even higher than MGD only. CD11B, which is a myeloid marker, you can see an increase also. And then what was interesting is we clearly found neutrophils, But it wasn't in 100% of the patients in each category. It was a section. It was a subset of the patients. Can you next slide, please? But the point is that we were indeed able to find them. And so then the question was whether we can make a correlation or any sort of association between the number of T neutrophils and the progression of Meibomian gland dysfunction. And the one way we were able to do that is by Priya Gupta was able to do a Meibom viscosity index. This was something that was established, I think, 2 decades ago or 3 decades ago, where you express the glands and you look at the quality of the gland. And you score the quality of the gland based on the features of the gland. So, for example, a 0 would be completely olive oil-like and clear, and a 5 or a 4 would be toothpaste-like, where you're expressing it as really toothpaste-like. And the scoring and the immunology and the flow cytometry were done completely in mass fashion, so there was no communication between the flow cytometrist and Priya. And what you can find is, indeed, we do see a nice correlation, both in the MGD only and in the MGD IMD. Sure, we didn't have as many patients in the MGD IMD, and most of them had a very, you can see, were two and above. But you can see a very nice correlation, especially when we looked only at those PMN positive patients. And the correlation was even stronger when we only looked at the PMN positive patients. And you can argue both sides. You can argue that, okay, we're selecting for the PMN patients, so we're kind of stacking the deck for us. But you can also argue that we're just selecting for patients that have neutrophils in their tears, and those patients have a higher association with Meibom viscosity index. So there seems to be a correlation. Let's just say the data show a correlation between the number of neutrophils and the intensity of MGD. Next slide, please. And what's interesting is both in the MGD only, you have 39.5, approximately 40% of these patients that were neutrophil positive. And in the MGD IMD subset, you had 66.7. So maybe you can argue that both of these different patient subsets are similar in pathophysiology, that it's a neutrophil mediated and might be recapitulated in our data. Next slide. I'm just going to zip through everything because I know we're running out of time. But I just want to show you, we've worked on, this is a collaboration with, or an IAR with Lipids, with Novartis, prior to that with Shire. Lipids, as you probably know, bounced around from companies. But basically what we showed in this paper is that Lipids inhibits neutrophil recruitment. Next slide, please. And we use this topically, and what we found with Lipids, we got a little bit more sophisticated with our Meibomian gland plugging quantitation. Next slide, please. We're also doing more imaging too. But with Lipids, we were able to reduce the number of neutrophils, and you can see the 3+ plugs, which are the largest plugs. Actually, the number of those plugs went down, suggesting that this drug actually is reducing MGD. Next slide, please. So the idea is that Lipids is actually blocking or preventing neutrophil recruitment, is where we think it's working. Next slide, please. And what's interesting is this was work done by Joseph Tauber. This is completely independent. In fact, I've never even talked to him. But essentially, he looked at TPP, which is the thermal pulsation, which is used for rosacea and also used for Meibomian gland dysfunction, versus Lipids alone. And you can see in the bottom, they basically found something that recapitulates our model, in that it improved patient symptoms and signs. And in the bottom, they say Lipids should be included in treatment for inflammatory MGD. So we felt pretty excited about that. Next slide, please. What was interesting is that, though, the Lipids, and I'm not showing you the data, did not inhibit the ocular allergy. So we have 2 diseases happening simultaneously, and it's not that surprising. You have a Th17 disease that's mediating MGD, and you have a Th2 disease that's mediating the eosinophilia and allergy, and both of these are happening at the same time and are initiated by the same antigen. Next slide, please. So what we saw was that lifitegrast, though it inhibited MGD, had no impact or no significant impact on ocular allergy signs and symptoms. And interestingly, that was what's shown in phase 2 trials when this was tested in humans in this conjunctival allergen challenge test, and that was basically abandoned. And I'm not putting this up to to say anything negative about anybody, other than to say that the model seems to be recapitulating what is seen in the clinic. Next slide. So we're advancing this notion. Right now we have 36 color flow cytometry. We also have single cell, and we have mass spec going on from patient tears. Next slide. And what we're doing, here's our 36 color flow cytometry. This is a UMAP, so it's compressed 36 colors of data onto a 2-dimensional plot. And what I'm showing on the left is a plot of normal blood, and what I'm showing on the right is a plot of MGD tears. And this is about 40 different patients. And you can see in the tears, there's an enrichment of neutrophils in these patients, and we're starting to do imaging and looking to better describe the interaction between, or the role of neutrophils in MGD. And so with that, I'll end. Next slide, please. So this is, need to thank a lot of people, including all the funding sources. I mentioned Novartis was one of these for IIR. Nancy Reyes, who's done all this work, she's now with Dompay. Chen Yu and Rose Matthew, and then our collaborators, Victor Perez, who we're closely collaborating with now, and the remainder of those who I've already named in our ophthalmology core. And with that, I'm happy to take any questions.
Thank you, Danny. Just to provide some additional context here, we have some folks from early stage development as well as late stage development. So we have a mix of people here. Yeah, I'll take any questions here.
I'm just using a throat lozenge. I hope I don't offend anybody.
Hi, I have a question. Can you go back one slide, please?
My computer just froze. Oh, well, there you go. Okay, sorry. Let me go back. Is the slide looking for me? Oh, somehow. I don't know why we're being blocked.
That's okay. I can just ask my question.
Okay.
I'm curious about the UMAP you showed earlier. It looked like there was a shift in the neutrophil state between normal blood and the tear. I'm just wondering if you think that's real or it's just experimental artifact.
That's a great question. No, we do think it's real. And we're doing an unbiased analysis to see which of the 36 markers are associated with that change. What we do, it's tricky, and it sounds like you have some experience, but we collect these patients not all on the same day, and they're not frozen and ran on the same day. They're collected every week, and we run them fresh every week. And what we do is we have all the same settings, and we have aliquots of the same person's blood, so that everything is anchored to exactly the same way it was done the week before. And then we can do some bioinformatic tricks to make sure everything is integrated nicely. And by doing that, you can begin to see how the plots change from patient to patient. So the number so that is anchored, and so we run the seeds off of that, and so we can make some claims about how these tears cells shift, and indeed that's a real shift.
I see. Thank you.
You're welcome. Thank you for the question.
Hello, Daniel. This is Vahan. Very nice talk. Thank you so much for sharing your work with us. My question is, I think I missed how you picked IL-17 to be the target to study in your model, and is there any genetic association between IL-33 and MGD? And do you think that's IL-17 is the best target for this disease?
Okay, so I'll start. There's 3 questions. The first one is, how do we come up with IL-17? It wasn't unbiased. We basically I knew how to play with T cells and from the lymph node in the dish. And so I wanted to see which T cell, helper T cell compartments sort of expanded in these mice. We knew that Th2 would expand. We saw interferon gamma expansion also, and that wasn't so novel. The most novel thing that we saw was that there was an expansion of Th17 cells. And at the time, this was, late 2000s, nobody had looked, or there was no credible evidence at the time that Th17 was involved in allergy, chronic allergy, or any kind of ocular allergy. So we got really excited about that. And we had these two pieces of data, and we thought, okay, maybe Th17 is causing the MGD. So we began to test. So it's kind of like that, often how science goes. You mentioned about IL-33 and MGD. There's not much data. I'm not an IL-33 expert, but I did my research before meeting with you all, and I don't see a tremendous amount of data on IL-33 and ocular surface diseases, to be honest. There's scant reports of IL-33 in dry eye. There's certainly nothing in MGD that I found, but maybe I need to look deeper. With respect to IL-17 being potentially the best target, maybe IL-23 would be a better target, because there is some notion that IL-17 can be important in homeostasis, where IL-23, which drives or sustains these populations, is actually more relevant pathologically. So if I were to design a drug based on my research, I would go after IL-23 or go after a neutrophil. What's interesting, and maybe we could talk about this later, is there's connection between IL-33 and neutrophils. So that might be something, you can hang your hat on. But again, these are sort of my nascent thoughts on IL-33.
Okay, thank you.
Maybe I'll just pause here. We have a roundtable session afterwards with some of the core folks, but people who aren't part of the roundtable session, any questions for Danny here? Okay, I'll take that as a no. So should we just stay here for the roundtable?
Yeah, unless somebody new that wasn't here is joining the roundtable, but I doubt it.